Okay. And we're starting in 3, 2, 1, go.
Our project is an in vitro surgical cranium model for brain mass removal by Alfredo, Mahmoud, Arnav, Cassie, and Melissa. First, I will start with the background of our project, explaining why it is important we develop a solution. Glioblastoma is the most prevalent brain tumor in adults age 40 and older, with over 18,000 estimated living cases in 2010. It is an aggressive type of cancer that forms from star-shaped cells in the brain called astrocytes. The picture to the left is an example of one in the frontal lobe. Treatment for most tumors include extraction by surgery. Traditionally, neurosurgeons remove brain masses by opening the skull through a craniotomy to ensure they can access the tumor and remove as much of it as possible. They are very high-risk procedures, and based on our research, they typically take about 4 hours. On average, neurosurgeons can be expected to perform about 223 cases each year, and over 75% are brain and spinal tumor removal surgeries. Other training methods include cadaver dissections, which are extremely expensive, in vivo animal testings, which are treated as unethical, and engineered models, which are fairly new. Here is an example of an existing model. This was 3D printed from the University of Malaysia. Although they did a great job with their cranial model, there are some drawbacks such as cost of reproduction, time development, and limited usability.
Our need statement is an in vitro training platform for neurosurgeons conducting craniotomies to surgically eliminate brain masses in brain tumor patients in order to reduce the mortality rate attributable to tumor complications and improve surgical abilities. The design objective is to create an in vitro surgical training platform to remove brain masses in cancer patients in order to decrease the mortality rate due to tumor removal complications. The main focus of the user needs is to improve surgical performance. The first requirement is that the device needs to help a surgeon's performance in terms of time they spend in the surgery, and after 5 training sessions, the time of surgery should decrease by about 15%. The second requirement is that the device needs to improve surgical performance in terms of the amount of mass removal. The amount of mass removed should be within 0.5 grams of the mass of the tumor. This improvement should happen after 5 training sessions. The rationale behind all of this is that the device needs to train surgeons to improve their performance in accomplishing the surgery while also minimizing the amount of extra tissue removed. Our evaluation methods are as follows. The average time and standard deviation of the time spent conducting the surgery compared before and after each training session. The time should be improved in a linear regression, and after 3 training sessions, the amount of mass removed before and after should improve also in a linear regression.
As previously discussed, we underwent different testings in our materials to construct our model, and we ultimately chose to continue with the polymer model. However, after our lo-fi design, we still faced challenges in scaling and size of our prototype. Once we were able to get the right printed PLA molds, we were able to cast our models more accurately. Also, previously we faced issues with the melting point of the gelatinous tumor inside of an also gelatinous brain. To fix this, we used gummy bears to construct the tumor, where they were melted and reshaped into a ball and chilled before being inserted into the brain. This is just one example of a craniotomy procedure.
To the cranium, and then to the cranium, and then
For our own protocol, we used drill bits, medical surgical kit, a surgical scalpel, and a wood burner with a blade. We began the procedure by cutting a circular pattern around the prospective tumor placement. The skin flap was then peeled away, exposing the bone where three 3/16 burr holes were made in a triangular fashion, which was then connected by 1/16 drill marks in order to easily remove the simulated bone layer, gaining access to the brain mass. Commonly in craniotomies, an electrosurgical unit is used to cauterize through the brain to gain access to the tumor. In place of that tool, we improvised with a wood burner and slowly separated the tumor adhered to the brain, successfully removing the tumor.
We focused our verification protocol on two variables, time and mass. Our goal was to verify that after attempting three training procedures on our model, both a statistically significant decrease in procedure time and an increase in mass removal accuracy are achievable. We conducted our verification protocol by having two users attempt three training sessions each. As you can see in the table on the right, we recorded the time of each attempt for each user. We also recorded the actual mass of the tumor and then compared that with the mass removed during each attempt. The final column of the table shows the absolute value of difference between the actual mass of the tumor, which is the third column, and the mass removed during the specific attempt, which is the fourth column. This value in the last column represents how accurate the user was in terms of mass removal. We used the absolute value of the difference because the user may remove less or more than the actual mass of the tumor. The top two parts of the table represents the data of the two users. The bottom part represents the average of the two users. For each user and for their average, we calculated the slope between the time duration of the first and third attempts, as well as the associated percentage of improvement. We also calculated the slope and percentage of improvement in mass removal accuracy for each user and their average. As you can see from the bottom two rows of the table, which again represents the average of the two users, the duration decreased by 24% between the first and third attempts, while the mass removal accuracy increased by 60% between the first and the third attempt. This slide shows a graphical representation of the linear regression test of the average results of the two users. The graph on the left shows how the time decreased after each training session. As you can see from the equation of the line above the graph, the slope was calculated to be negative 1.3417, which means that the time duration decreased by 1.3417 minutes after each training session. This linear regression test had a p-value of 0.014, which is less than 5%, which means that we can conclude that there was a significant difference in time duration. Also, the R-squared value of this regression test was 0.9912, which shows that there's a strong relationship between the time duration and the number of previous training sessions. The second graph on the right shows how the difference between the actual mass of the tumor and the mass removed during each session decreased. This means that the mass removal accuracy has improved after each training session. As you can see from the equation of the line above the graph, the slope was calculated to be negative 0.12, which means that the difference in mass decreased by 0.12 grams after each training session. This linear regression test had a p-value of 0.015, which is less than 5%, which means that we can conclude that there was a significant difference in the mass removal accuracy. Also, the R-squared value of this regression test was 0.9977, which shows that there is a strong relationship between the difference in mass and the number of previous training sessions. To sum up, both linear regression tests verified our goal that training sessions on our model decrease procedure time and increase mass removal accuracy.
For our future models, we want to implement a model of metastasizing tumor in order to mimic a more intricate brain surgical procedure, and we already have a plan for it. We also want to work on our protocol so that it accurately follows the actual surgical procedure from start to end. Currently, our tools are good enough to meet the requirement of a current protocol, but as we improve our design, we will need more complex tools. However, our current model is designed to scale and the materials were carefully selected to mimic a human brain. We still think that it can be improved and developed to be more consistent.